physicians from various parts of the world and especially from western parts, they meet about 6 to 10 years at intervals of 6 to 10 years and they modify Rome criteria for diagnosis of these functional gastrointestinal disturbances. Functional means that they don't find any organic pathology, that's why they call it functional. And gastrointestinal disorder means that it can be, the problem either can be esophagus or can be in stomach or can be in the small bowel, large bowel till anus. So starting from esophagus to anus, these functional problems can be there, because you know there is nervous system in the gut. This is the enteric nervous system starting from esophagus till anus, and this nervous system is influenced by hypothalamus. The autonomic function is regulated by brain. Even if there is no brain, this nervous system can propel whatever food material enters inside esophagus, but it modulates, the brain modulates the activity. That's why when we face any stress, any anxiety, depression, our gut also gets affected, because the brain activity affects gut and gut activity affects brain. So there is bidirectional link. That's why they call it functional, because it is the disturbance of the neurotransmitters. Neurotransmitters, they call the term neuromodulation. The problem is in the neuromodulation, not any organic pathology. So I was talking that Rome criteria, they meet every 6 to 10 year interval and they modify based on the research they have developed in that time period. So if you see in Rome 3 criteria, they had told that we can define IBS if patient has recurrent abdominal discomfort for 3 months. This recurrent abdominal discomfort should be for 3 months and it should be associated with 2 or more of following. So one is relieved with defecation. Second is change in frequency of a stool. Third is change in consistency of a stool. So if any patient has any bloating, discomfort or feeling of distension for 3 months, and in 3 months they have specified that in 1 month there should be 3 times, and that should be associated with relieving after passing a stool, or if there is change in frequency of a stool. Let's suppose patient was having once daily a stool and now started having 4 times a stool. So this recurrent abdominal discomfort appeared after change in frequency of a stool or appeared after change in consistency of a stool. So the onset was associated with change in frequency of a stool or change in consistency of a stool, or this discomfort relieved after defecation. So this was Rome 3 criteria. After giving Rome 3 criteria, after 10 years they found that we are over-diagnosing IBS. We are diagnosing other functional gastrointestinal disorders like functional constipation, functional diarrhea, functional esophageal disorders, functional heartburn, functional chest pain. under the umbrella of IBS. So they then told that let's remove this discomfort with pain. So patient should have abdominal pain, and let's remove this relieved with, either it can get relieved or it can get increased with defecation. So change with defecation, so it can go in bidirectional. And rather than telling onset, let's call it associated with frequency of a stool, change in frequency, or associated with consistency of change. So this recurrent abdominal pain is not only onset after change in frequency of a stool, but can get relieved with change in frequency of a stool or change in consistency of a stool. They thought that it would be appropriate, it will not overdiagnose other functional gastrointestinal disturbance. But if you see this criteria in our populations, does it apply? I have seen very few patients who have told me that I have abdominal pain and that is associated with relief or change in defecation, or for change in frequency, or associated with change in consistency of a stool. What I encounter, or what patient tells in their local language, different people in different parts of the world have different vocabularies for describing their symptoms, and most of the patients that I see, they tell that in their local language, sola hanne. I cannot translate this into English language because I don't know the English word for this, because I told that different parts of the world have their own vocabularies, so it is difficult to translate. So I see this. Second symptom, I see that they tell that something is traveling from either side to side or up to down, like bowel is moving from this direction to this direction, or something up to down. So traveling sensation in abdomen, there is traveling of bowel from side to side or up to down. Third is, they tell that abdominal discomfort. Fourth is, this abdominal discomfort is both upper abdominal and lower abdominal, and also generalized abdominal discomfort. Whatever I see IBS cases, I see this type of symptoms. Fourth, they call bloating distension or distension of abdomen. Fifth is, I have to go to bathroom just after eating food. That is increased gastrocolic reflex. This is explained by visceral hypersensitivity. You know, in IBS there is visceral hypersensitivity. So there is exaggerated gastrocolic reflex. So I see these types of symptoms in IBS. And you can see that I have not written anywhere abdominal pain. Now I am writing it abdominal pain. So in 6th number I have written abdominal pain. So you can see the most common symptoms are these, and the least common is abdominal pain. So we are under diagnosing IBS with this criteria. If you go with Rome 4 criteria, they have included pain, but the part of the world where I am currently practicing, I don't think this is applicable. And I searched what criteria can be applied to this part of the world, and I found one Asian criteria. And what they have written in their criteria, that patient can have any type of discomfort, either bloating, distension, or whatever I have written here. Patient can have any type of discomfort, or it may be pain, and that should be associated with one of following. In Rome they had written two of following, but here one of following. One, either relieved with defecation, or change in frequency of a stool, or change in consistency of a stool. So in our part, I think, based on my personal experience, this criteria is more suitable. It will not either overdiagnose and neither underdiagnose. I have also seen some studies, they have compared multiple criteria from Rome 1 to Rome 4 and previous Manning criteria, Asian criteria, and in this part of the world, this criteria better diagnose IBS. This criteria is the sweet spot rather than going for Rome 3, Rome 4. Obviously this should be present for 3 months, they have mentioned, but this time duration we can judge clinically also, because some patient I see in 1 month time duration they undergo various investigation, endoscopy, stool examination, stool for occult blood, and they find nothing. So we can't wait that, oh, let's wait for 3 months and then I will diagnose IBS. So we can judge clinically as well. What is the explanation of the symptoms of the patient?